All right, so here is our last exam of neuro, which is exciting, neuro, and MSK. I've enjoyed tutoring you guys. So this is part 2, and I threw in some questions today, so might be fun. Okay, so first lecture, meningitis and encephalitis by Yance. Okay, so meningitis is that inflammatory disease of the leptomeninges, which is the arachnoid and pia mater. So there's going to be an abnormal number of white blood cells in the CSF, which we'll break it down and talk about it. And then bacterial meningitis, that's usually what we think about when we talk about meningitis. And it reflects the infection in the arachnoid space and the CSF in the subarachnoid space in the ventricles. There's 1.2 million cases worldwide and 135,000 deaths. So, and it's got like 1/4 of people who get it die. So that's why it's really scary and important to talk about. Okay, so encephalitis versus meningitis. So you may or may not know before you had this lecture what the difference between the two are. The symptoms pretty much overlap, but meningitis may be uncomfortable. They may have headaches. They've got neck stiffness, but they're cerebral, they may have vomiting, anything like that, but their cerebral function is normal. They don't have an altered mental status. They don't have any personality change or motor sensory deficit. So meningitis basically sort of becomes encephalitis when you have all the meningitis symptoms, plus you've got that altered mental status. Motor changes or personality changes. They become a different person, so to say. Okay, so this is really important to know the age. So basically, they can ask in a question, a newborn presents with, and then it tells you a typical meningitis, like, well, it's a newborn, maybe not, but they're crying more, they're really fussy, they've got bulging fontanelles, which are those soft spots, they've got a really high fever. That's how a newborn presents. They present a little bit different, but it may say, what's the most common organism? And you have to know what the organism is in order, because they might just straight up ask you what's the organism, or they might go a step further and ask you what's the treatment, or make you think all the way back to first year, and you have to know, well, what does it look like? Is it gram positive? Is it gram negative? Is it diplococci? Is it cocci? Is it a rod? So you'll have to know all of that. So, which will break it all down. But we're going to just start with, what is the organism? So newborns. These tell you all of the organisms, but what I would think about and know the most would be the most common. So in newborns, group B strep is the most common. And so if you think about, why is group B strep the most common, in mothers, or before the baby's born, they swab moms twice for group B strep. So if you think about somebody that didn't have prenatal care, or you think about somebody in a third world country, for some reason, they didn't get swabbed, they didn't get treated, so we didn't know they had it. That would be their baby. This newborn might be somebody that has this group B strep. So it's like colonized, it could be in the vagina and like travel up to the uterus and get to baby. Strep pneumo, I think of the MOPS mnemonic for strep pneumo, and I meant to put that in there, but meningitis, otitis media, pneumonia, and sinusitis all are caused by strep pneumo. So strep pneumo is the most common cause of meningitis in adults. In our immunocompromised and those over 50, but really like immunocompromised, think people with a lot of chronic conditions, or think somebody with like maybe HIV or somebody on cancer treatment. Those people are more susceptible to listeria. Teenagers, the most common in teenagers are Neisseria meningitis. And how I remember that is sort of like, I think about, well, what's the other Neisseria that we talk about and learn about in micro? That's gonorrhea. And so what age category are like gonorrhea, chlamydia, and other like STDs most common in? It's in teenagers. So that's how I remember Neisseria meningitis is the most common meningitis in teenagers. So the major ones to remember: group B strep, newborns. After we get out of newborns, adult or kids like 1 month to 2 years, it's going to go to strep pneumo. Then we get to teenagers, most common is going to be Neisseria meningitis. Adults, most common, strep pneumo. And then immunocompromised listeria. So if you've got your thinking cap on, what can we do to prevent against all of this before we ever make it to the hospital? Well, we've got vaccines. We've got the meningitis vaccine, and we've got the pneumonia vaccine. So these help prevent against bacterial meningitis. And then we swab moms for group B strep, and if they're positive, we're going to treat them so their baby doesn't get it and they don't have meningitis later. So just things to think about. Okay, bacterial meningitis. So it's got this classic triad, which we had kind of discussed, of fever, or they present usually with a headache, and then that fever, nuchal rigidity, and then that change in mental status, and that's going to go with our encephalitis instead of meningitis, and then nausea as well, and that could be caused too just from having a headache. Absence of all of these symptoms are going to essentially exclude bacterial meningitis. So I had a patient last month when I was in my ER rotation. Well, actually, I had 2 patients the same day, which was odd. And their PCP told them, well, you probably need to go to the ER for a lumbar puncture because you probably have meningitis. Then when we teased out the situation, because they had headache, but like I was watching them talk and they were moving their neck fine. So I'm like, it's not meningitis. And then they had no fever, but they were like dizzy and had a headache. So, but the thing too is that, remember we said like 1 in 4 people with bacterial meningitis die of it. So if these people had these symptoms for like 5 days, so by 5 days you're going to either be getting better or you would have been dead. So just something to think about in the back of your mind. Okay, so nuchal rigidity, aka neck stiffness. If you're talking to a patient and they're nodding their head and they're looking down at the floor, and then they look over to their right and over to their left, and they, let's say, put their head on their hand, and they're constantly moving their neck like everyone else does, then they don't have nuchal rigidity. So passive or active flexion results in inability to touch chin to chest. So first thing, you're noticing that they're not moving their neck much. First thing that you've got to do is say, hey, take your chin and put it to your chest. If they can't do that, you do it for them. See what happens. See if they can do it or not. We've got these 3 signs to test for meningitis. Now, these aren't perfect tests. Actually, when we did it in lab, in like EPC lab, I, for some reason, have like positive Brzezinski sign, but that doesn't mean I have meningitis. So a patient may have a positive test, but that doesn't necessarily mean that they've got it. So a Koenig sign is, and we've got pictures, is where you take the patient, they're lying with their hips flexed to 90 degrees, and you extend the knee. So there's positive when there's going to be that resistance to extension. So let's look at a picture and then we'll come back. So right here, we've got the leg flexed, but it can't be completely extended. So Brzezinski sign is going to be lying the supine position, and then you passively flex the head up toward the chest. And if they flex their knees and hips, the test is positive. So here's our picture. The doctor is moving their head forward, and you can see this guy's knees come up. So what does this mean? Like, why in the world do I have a positive? And why does this work? So in OPP, we talk about fascia and how everything is connected. So if you think about having a string from your heels all the way up to your head, and and it's really taut. I now flex this patient's head forward. That is going to put pressure on our fascial planes. So this is putting pressure, increasing pressure as we move forward. So if you think about it, if we're taking a string and we're pulling it even tighter, it's going to want to bend. So it's going to bend the knees so it gets some slack. Same thing with Koenig sign. So we're straightening out that knee, and it's pulling more pressure on the fascia, and that's what's creating and on the meninges itself, and that's why that they feel like they need to flex instead of being completely extended. Okay, so and then our last one is the jolt acceleration. If they rotate their head quickly, it's positive if they report an increased headache. So you can imagine if somebody has got a terrible migraine anyways, sometimes like movement makes it worse. So it's not super sensitive for meningitis. So you have to use lab testing, which we'll talk about, and you have to use your clinical skills, good history, and check the vitals. They are vital to figure out, okay, what's going on here. Okay, so lab studies, CBC. So white blood cells usually are elevated. And as you've talked about in heme, there's something called a left shift. So when our neutrophils are elevated and our white blood cells are elevated, and then we see neutrophils are elevated, that's a left shift. And so when they originally did CBCs, you actually saw it move left. So that's why it's called that. Coag studies might be important. CMP might be important to look at, like our sodium, anion gap, but blood cultures, super important. So it might help us reveal the organism. So if they're septic, sometimes the LP may not give us the data we need, but the organism is in their blood. So blood cultures are important. It can help us get a sensitivity report so we know what antibiotic would be best to give them or what they're resistant to. And then it's important to look at the CSF as well, which is what we're getting to and why we're getting a lumbar puncture. So when do we get a lumbar puncture? And when do we not get a lumbar puncture? So you need to get a CT of the head before you get a lumbar puncture if they're immunocompromised. So this is when good history comes into play. History of central nervous system disease, like do they have a mass? Do they have a stroke? Do they have an infection that we already know about? New onset of a seizure. If the patient comes in and they're like, oh yeah, I had a seizure today. Well, I mean, they're probably not going to say it like that, but let's say EMS brings them to the ER and they're like, they had a seizure and that's why they're here. Then, that's a problem. If you look in their eyes and you notice papilledema, we've got a problem. We can't do a lumbar puncture first. If they've got abnormal level of consciousness, if they've got altered mental status, if they can't answer 2 questions or commands back to back, or if they've got any focal neurological deficit. So I sort of think, do they have anything else besides headache and like nausea and neck stiffness? Do they have anything that would, anything outside of what I would call meningitis? Do I think it's encephalitis at all? Or do they have any neuro type of symptom or immunocompromised? Then I'm thinking, let's not do the LP, let's get the CT. So if you think about it, if I go to the CT scanner's down, we got to go to the second floor because first floor CT scanner's not working. Oh, well, there's a patient in front. It's going to be like 30 more minutes. This is delaying treatment. If we're delaying treatment, and we've got like a fourth of them are going to die, then this may delay therapy. This is going to be delaying therapy and delaying the patient in getting better. So we're going to talk about what you do in this situation. If the LP is delayed, we need to get 2 blood cultures. And the reason why you get 2 instead of just 1, there's normal flora on your skin. Sometimes a blood culture will just pick up normal skin flora. So we get 2 blood cultures because it just may not grow out anything. And then B, it might just grow out like staph epi or something. And we know that that's not what we're looking for. 2, if it's delayed, we're going to get our blood cultures first. It's just a blood draw. It's real quick. And then immediately we're going to start antibiotics. And then also to decrease that ICP that we talked about was increased, we're going to give them steroid, which is dexamethasone. So giving antibiotics before the tap can sort of mess up the gram staining culture, but we already got blood cultures cooking and they take like 3 days to come back, but we can get a preliminary in about 24 hours. So that's why we just go ahead and give antibiotics. Like we can't wait. We've got to go now. So this is like speed. It's like a race to the finish line. Meningitis is bad. Okay. What do we measure? So let's say we didn't need a CT scan or we did need a CT scan and now we're back. Now we're going to get the lumbar puncture. We're going to get 4 tubes. Starting with tube 1. So tube 1, we're going to get our cell count. And we're going to talk about what all of these mean in the differential. So how many cells do we have? Do we have neutrophils? Do we have lymphocytes? Like what type of cells are they? And that can aid us in treatment and figuring out what organism we've got. Tube 2 is going to be for glucose and protein. We're going to talk about what if glucose is normal or if it's low, and then what elevated protein levels mean, which we talked about a little bit last week. And then tube 3 is going to be a gram stain, and it's also going to provide our culture and sensitivity. And then tube 4 is pretty much our extra cell. So whoops, the lab dropped tube 1 and we couldn't get our cell count. Or they didn't have enough. It got contaminated, and now we couldn't get a culture and sensitivity. Well, we got that extra tube just to help them out. So it says cell count and differential, but really tube 4 is like our extra one that we're going to save just in case. Sometimes people use serum lactate. It's elevated if it's in bacterial infections. And then just remember in the back of your mind, if you saw a bloody, and sometimes they're bloody if you like mess up and don't do it right. But if it's bloody or lipemic CSF, that is related to SAH. So our subarachnoid hemorrhage. Okay, so I took this. It wasn't in your PowerPoint slides. I'm trying to remember. It is irrelevant. Okay, so 10 mils of CSF in 4 plastic tubes. I have never collected LP for meningitis before, so I'm not exactly sure. I have collected it for hydrocephalus, and the amount of CSF is based on weight. So if you collect too much too fast, it can drop their blood pressure and make them really sick. So it's probably going to be 2.5 each. I know that I collected 10 mils, or I collected 20 mils on a kid, but had like severe hydrocephalus, and we split it into 2 tubes. And actually, like the whole tube 4 thing was because 2 tubes got contaminated, and like the person did not have meningitis. They had nothing wrong. They were just there for surgery, and it grew out Klebsiella. So we had an extra tube, sent it off, and nothing grew out. So I'm not 100% sure, but I would say probably less than more. Okay, so I stole this from Up to Date, and it wasn't in your lecture slide because it seemed confusing, so I added this. So I thought it was a good chart. So we start out, I think the patient has meningitis. So then we ask ourselves, are they all of those neuro-y questions? Are they immunocompromised? Do they have a CNS disease? Did they just have a seizure today or this week? Do they have papilledema? And papilledema is one that they ask about a lot. So I would just remember that one, because I guess it's something that people don't think about, but your eyes are really close to your brain. So if you think about papilledema, think about it like there is so much pressure. We talked about it with hydrocephalus. There's so much pressure that it's putting pressure on your optic nerve and causing the papilledema. So that's why that's bad. Altered consciousness or focal neurological deficit. So do we have any of that? Let's say we do. We do have that. Let's get blood cultures right now. Then after that, let's start them on antibiotics and dexamethasone. From there, we're going to do a CT of the head. And then from there, we're going to look at the CT and say, do we have contraindications for a lumbar puncture, or do we not? If we don't, we're going to perform the lumbar puncture. Like if they've got a huge tumor or something that's causing this, then maybe we're not going to do the lumbar puncture. Or if we think that by doing the lumbar puncture, they're going to herniate, then we don't do it. That's the whole reason why we wouldn't do it. We don't want to herniate them. If we can do the lumbar puncture, everything looks okay on the CT scan, then we're going to continue the therapy, or, I mean, sorry, if there isn't a contraindication, then we will perform the lumbar puncture, and then look at the CSF, look at the gram stains, and consider what we do. So let's say we have a suspicion they don't have any of that neuro stuff. We get blood cultures and a lumbar puncture stat, and then we start them on dexamethasone and antibiotics. If it's consistent with meningitis, then we're going to look at the gram stain. If it's positive, we know, okay, it's bacterial. And then from there, we're going to figure out what therapy we should do based on, basically, first off, based on their age and based on what they, what the stain looks like. And then if it's not bacterial, then we're going to say, okay, is it fungal or viral, or is it something completely different? So I think this is helpful because in your test questions, and like meningitis is just something that they love to ask about as far as like board questions or practice questions, you'll get a lot of meningitis questions. And one of the things that they might ask, maybe not on step 1, level 1, but like definitely toward like step 2, level 2, but also in like step 1 questions, they love asking, like, what is the next step? So, and on your test. So first step after we suspect, blood cultures. And then if they don't have altered mental status or neuro stuff, then we do lumbar puncture. And then we treat them and go from there. Okay. I hit that hard because I think it's really important. Okay. So here's the breakdown of our CSF. So we talked about that first tube getting a cell count and differential. Also like opening pressure. So opening pressure is going to be really elevated in bacterial. And you're thinking like, what in the world does opening pressure mean? So you put in this needle, and if you've got like CSF coming out at you, like drip, 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 then that's high. If a normal, it's just going to be drip, 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 drip. That's kind of how I think about it. So that's what that means. So we get the cell count and differential with our first CSF. The lab tells us there's a ton of cells. Then, because normally there's not supposed to be that many cells. There's a ton of cells and there's a bunch of neutrophils. Neutrophils, I automatically start thinking, like in a CBC, if I see high neutrophils or neutrophilia, I automatically think, okay, bacterial infection. If I see a ton of lymphocytes, let's just say in a CBC, I'm going to think, okay, it's probably a viral infection. So if you ever, little side note, like if you ever need help reading labs, I used to be a lab tech, like I can help you read some of these labs. So just the basic breakdown, just on a CBC, I see lymphocytes, that's more, I usually think more viral. If I see neutrophils, that's usually what I'm going to think is going to be bacterial. So it's very similar when I look at CSF. High neutrophils, I'm thinking bacterial. High lymphocytes, I'm thinking viral or maybe fungal. Another thing that, so if I ordered a CBC, I'm not looking at CSF, but I ordered a CBC and I see a high white count and I see high neutrophils. But I was told last week they took, or 3 days ago, they took steroids. Steroids can increase that number. So people may think, oh, it's a bacterial infection, but it's not. It's just sort of falsely elevated because of, it's not, well, It's just elevated because they took steroids. Okay, so back to it. Bacterial neutrophils. So protein is going to be elevated in bacterial infections. And it's going also to be elevated in fungal infections, including tuberculosis as well. Viral is going to be normal to elevated. So protein's pretty much going to be elevated in all of them. So don't really worry about that. So CSF serum to glucose ratio. So I'm just thinking like glucose. So bacteria like they've got to eat too. So I think of them as going through and like eating up all of the glucose. So normally we've got glucose in our CSF, but there's a bunch of bacteria in there. They're eating up all the glucose. So now we've got decreased glucose in our CSF with bacterial meningitis. Viruses, they're not little bugs in there. So they're not going to be. So usually our CSF is going to be normal. Fungus, tuberculosis, also little organisms, and we're going to have low glucose. Gram stain is only positive in bacteria. So if they're trying to differentiate between bacterial and viral, they're not going to give you a gram stain. You need to know that our cell count is going to be low in viral, but high in bacterial. We're going to have neutrophils in bacterial and lymphocytes in viral. And we're going to have decreased glucose in bacterial, but normal in viral. For fungal, we're going to have lymphocytes instead of neutrophils, but we're also going to have low glucose. So to differentiate between bacterial, viral, and fungal, viral and fungal have lymphocytes, bacterial have neutrophils, but bacterial and fungal have low glucose and viral has normal. And then if they act and look like they have TB and they've got fungal looking CSF, start thinking tuberculosis. But usually they just make you differentiate between bacterial, viral, and fungal. Okay. Gram stain. So here's our favorite ones. So Neisseria meningitis. Remember, that's in teenagers. Strep pneumo, usually adults. Listeria is in our immunocompromised. And then then they just may give you H flu. So Neisseria is going to be gram-negative diplococci. So I know pink and purple, they both start with P's, but I think of purple positive. It's a longer word. Purple's longer. Positive is a longish word, or they're about the same size. So I think purple positive. So strep pneumo and Listeria are positive. And strep pneumo are diplococci. So make sure that you know what it looks like. So that's why I included these pictures, because it may just show you a picture and you have to know. Listeria are going to be rods. So little purple rods. Haemophilus influenza is going to be gram-negative, so they're pink. Cocoa bacilli. And I think of like Haemophilus sounds like ham. And you know what else is a food? Cocoa, chocolate. So we got chocolate and ham. Go together. I don't know. That's what I think of. Okay. So both of our diplococci is going to be Neisseria and strep pneumo. Strep pneumo is going to be positive purple, and Neisseria is going to be pink and negative. Okay, so here is our treatments. So now we're putting on another layer. Strep pneumo is going to be Vanc and a third generation cephalosporin. Neisseria meningitis is going to be just a third generation cephalosporin. And I included, I looked through all of your lectures and I really thought that it was somewhere in there and I couldn't find it, but I know it's important for boards and like practice questions. So I put this little star. If a patient comes in with Neisseria, it's like really important. I don't know why they include it. If a patient comes in with Neisseria, like all of their contacts get rifampin. The other types of meningitis, they don't get like prophylactic antibiotics, but for Neisseria, they do. So let's say there was an outbreak at the college dorm. The roommate is going to get rifampin, and the person with meningitis is going to get this third generation cephalosporin. Something else about Neisseria, they break out in a rash and they've got like purpura. So purpura and petechiae. So that like further helps you know what they are. So teenager with like some purple rash and they've got meningitis symptoms, think Neisseria, and know that contacts get rifampin. Okay. Listeria, they get ampicillin or penicillin G. Usually the go-to is going to be ampicillin. So if you're thinking, okay, I need to start this patient on an antibiotic, and because I just took their lumbar puncture, now I'm putting them on prophylactic antibiotics. I'm going to throw some dexamethasone because we want to decrease ICP, and I'm going to start them on empiric antibiotics, which is going to be Vanc and cephalosporin. But I'm like, but they're immunocompromised. Throw in ampicillin. Okay. So we're always going to start out when we're like not sure because we don't have we've got to wait 3 days to get the report back. So for sensitivity, I'm just going to start the patient on dexamethasone, Vanc, and a third generation cephalosporin. So like, let's say vancomycin or vancomycin, ceftriaxone. And I'm going to throw in some ampicillin if they're immunocompromised. If they're not, I won't give them ampicillin. Haemophilus and E. coli would also be third generation cephalosporins. And strep B or strep pegulaceae. I'm not good at that one. Anyways, it's also going to be AMP or penicillin G. And I think usually they give kids penicillin G. And for Listeria, they usually give ampicillin. So, but anyways, they're both listed. There's always alternative therapies if they are allergic to the recommended drug. So like for strep pneum, I mean, I don't think it's as important to remember. I would say if you're going to remember any alternative therapies, I would know that strep pneumo, you can give a penem, like meropenem or a fluoroquinolone. Okay. Chronic meningitis, they might need routine evaluations, and it's going to be complex. Think about steroids. It's not important. Viral encephalitis, they're going to have that altered mental status that we talked about. They may not have like all of the meningitis symptoms and that irritation. Seizures are really common. So if they've got that seizure, fever, and that altered mental status, start thinking viral encephalitis. Some causes, they could have parotiditis, like mumps. They could have flaccid paralysis. It could be confused with Guillain-Barré. Start thinking, okay, maybe West Nile virus. It could have tremors of eyelids, tongue, lips, extremities. That is common with St. Louis or West Nile encephalitis, or I think West Virginia encephalitis. Hydrophobia, if you think hydrophobia, if they're scared of water, if you ever hear that, just automatically think rabies. And then plus everything else. And then if they've got like a vesicular rash, think shingles, zoster. Okay. Herpes 1, encephalitis. It's the most common fatal encephalitis worldwide, and it involves the temporal lobe. So no, with HSV1 encephalitis, absolutely no, it's the temporal lobe involvement. And we can see that right here. This like wider area. It can be seen on imaging. MRI is the best. So the gold standard is going to be looking at HSV CSF. So we see a negative gram stain and we think, okay, they've got normal glucose. They've got this altered mental status. I don't know what's going on. Let's check them for HSV and see if that's what their problem is. Maybe do an MRI. So just like you would treat herpes simplex, like shingle, like how you would treat shingles or how you would treat a cold sore or genital herpes, you treat it with acyclovir or valcyclovir. And since it's severe, it's encephalitis, we're going to give it IV. So focal neurodeficits are going to be less than a week in duration. So hopefully they come to you before sooner rather than later. They could have cranial nerve deficits, hemiparesis, dysphagia, aphasia, ataxia, or focal seizures. Most of the patients have a fever, so they're going to have similar symptoms to just regular meningitis. They may have other things like urinary and fecal incontinence. So you're going to know something's going on here, and it doesn't make sense. Or just meningitis kind of symptom. Behavioral syndromes. So hypomania, you'll talk more about hypomania when you talk about bipolar 2 disorder in the spring. So it's going to occur in the initial phase. So because of the inflammation of the temporal lobe or in the limbic system. So with hypomania, they're going to have an elevated mood. They don't feel like they need to sleep. They've got big, like grandiose thoughts about themselves, big self-esteem, really animated, and either like hypersexual or they like start gambling all of a sudden and they didn't do that before. But not hypomania is like, it's not to the point where they would need hospitalization for their mood disorder. Now, if they have HSV like encephalitis and they're causing this, then yeah, we're going to have to like have hospitalization for that. But if it's just plain old hypomania, like related to like bipolar, then they wouldn't need to be hospitalized. Kluver-Bucy syndrome. I think that was talked about last year. It's excessive oral tendencies. They lose anger and fear response, and they've got that increased sexual activity without regards to appropriateness and visual agnosia. And they've got bilateral temporal damage. So I think of like Gary Busey when I think of Kluver-Bucy syndrome. And I've got a picture of him later. So if not, if you don't know who he is, look him up. And after you look him up and like just watch a little bit, you will remember Kluver-Bucy syndrome. Because all of his everything, like he has like every symptom pretty much. Because like he's angry, has no fear response, has like a huge mouth. So anyways, not appropriate. So there we go. Okay, so pharmacology. So we've already talked about a lot of the pharmacology, but it's kind of like we're gonna talk about it again. So first dose of antibiotics should not be withheld. even if the lumbar puncture is delayed or imaging is done. So remember, we're going to get our, if it's not delayed, we're going to get our blood cultures, then we're going to get our lumbar puncture, and then we're going to start antibiotics. Again, with regular antibiotics, we're going to give the empiric dose, and then once we have the pathogen, we're going to like back down and give them what they need, not give them every drug in the book. Okay. Mannitol can quickly reduce ICP. The issue with mannitol is it can cause hypotension, or it can cause like renal dysfunction. It sort of gets rid, I think of mannitol as getting rid of all of our electrolytes. So you have to watch their electrolytes. Hypertonic saline is great for reducing cerebral edema, but it also can have effects like you're giving them a bunch of sodium. So you got to watch their sodium. So if we've got low, high to low, if we take our sodium from really high and decrease it too fast, the brain will blow. So we got too much ICP. From low to high, the pons will die. So not good. So you can hurt the pons if you give sodium too fast. So make sure you're monitoring serum sodium. And then we've already talked about steroids. So here's a steroid, dexamethasone. Permanent hearing loss or neurologic deficits are not uncommon with pneumonia due to these like inflammatory pathways. So early administration of steroids can diminish the rate of hearing loss and other neurological complications and maybe death. So it's good to give. It's really important in pneumococcal meningitis. The only time that I missed a question, it was a practice question on meningitis, because I said that you give dexamethasone for Neisseria meningitis, and that's the only one it said. I think it was like maybe UWorld. I'm not really sure, but it's the only bacterial meningitis that you would not give dexamethasone with. With all the rest, you give dex. But if you're suspicious or they do have Neisseria, you don't give dexamethasone. I missed that question, and now I remember it forever. So bacterial meningitis, we talked about strep pneumo, Neisseria, and listeria. Healthcare associated is going to be more of staphylococcal, so like MRSA or MISA, and aerobic gram negative. So adults think strep pneumo. When do we start antibiotics? So we talked about third generation cephalosporins as well as vanc is what we're going to give. So ceftriaxone and cefoxamine, it are reasonable choices to give for empiric coverage. If we're thinking about infants, elderly, or those that are immunocompromised, add in ampicillin to cover listeria. So we have got no known immune deficiency, but if we have no known immune deficiency, we're going to give ceftriaxone or cefotaxime and vanc. And then if they're above 50 or they're immunocompromised, we're going to give AMP. Okay, so recommended empiric therapy. Less than a month, we're going to worry about strep B. So we're going to give ampicillin and cefotaxime or ampicillin and aminoglycoside. If they're above that, we're going to think, okay, it could be strep pneumo. So we're going to give our plain vanc and third generation cephalosporin, really all the way up to 50. If they're greater than 50, we're going to add ampicillin because we're worried about listeria. Or if they're any age and they're immunocompromised, we're adding listeria. We're adding ampicillin to prevent listeria. Okay, so here's some surgeries. So fractures, penetrating trauma, post neurosurgery or CSF shunt. This is what I've seen most. We're going to have vanc and honestly a third generation cephalosporin or a penem. Or not a third generation, just a cephalosporin with penetrating post neuro or CSF. And I usually see cefepime given. So I don't remember being asked about any of those. Okay, viral meningitis, usually it's self-limited course. It resolves without therapy. If they're starting to have encephalitis, you see it on imaging, or they start having all this crazy ultramental status, let's start thinking about acyclovir. If it's fungal, so remember our fungal looking picture, we've got lymphocytes and we've got low glucose. Candida is the most common cause of fungal meningitis. And our treatment choices are going to be amphotericin B and fluticetazine. Remember, Ant B is going to poke holes in all of our cells. I remember in micro, I think it was micro, it's at our farm, learning that amphotericin B, it saves 50% of the patients from dying, but also there's a 50% chance in death just because amphotericin B is like such a big fungicidal and kills our cells too. Fluconazole is usually a step down therapy. And then voriconazole can be also used as step down. So Ant B and fluticetazine are what are initially given. So fungal meningitis, don't want to mess with that. Scary. But Ant B is going to get to our brain. So that's why we give that. Big dog. So again, super toxic. It causes all sorts of bad things. Hurts our kidneys, causes anemia, causes convulsions, anaphylaxis, all this bad stuff. There's been a major shift since the 1960s because of vaccination. Worldwide, mumps is a cause in low vaccinated populations. Herpes virus is the most common in the US. And then everything else. All the other West Nile, Arbu, Adeno, all the other viruses. Herpes virus, remember we treat with acyclovir. In those that are resistant, we're going to go to foscarnet. Acyclovir is nucleic acid analog from I just completely lost all my words. But I just would know it's like a nucleic acid analog and it's used to treat herpes. That's probably all I know with that. Foscarnet is going to inhibit herpes virus DNA polymerase, RNA polymerase, and HIV reverse transcriptase. I just gotta know what that does. and remember, it's treating herpes that's resistant to acyclovir. CMV, it can, we talked about it last week with Campbell, and it can infect the brain in immunocompromised patients. So think about HIV. It's important to initiate our heart therapy in HIV, and because that can improve survival. So if we've got a low viral load, and we've got high CD4 counts, then that patient probably won't be getting CMV. Treatment for this is going to be ganciclovir and foscarnet. Toxoplasmosis. Remember, routes of transmission are going to be foodborne, mother to child, human feces, cat feces, like changing litter boxes. Treatment is going to be pyrimethamine and sulfadiazine. So I would think that there probably could be one question about, probably not herpes, either like CMV and tox. I mean, there's probably going to be a herpes question, but like they know you're going to go for acyclovir. So I would say like acyclovir resistance, so no, it's foscarnet. And then probably going to be a question like treatment wise, like what's the treatment for CMV and toxoplasmosis. So make sure that you know these, because they're like a little weird. You know, they're not just our normal go-to drugs. So remember with this drug that it has a side effect of megaloblastic anemia. So we're going to add the leucovorin, folinic acid, which reduce the risk of hematological toxicity. Okay, so here is my review slide. And I put in red the things that I thought were positive. So the things that are red are probably positive for this exam, but I would just save these antibiotic slides because they go over every antibiotic that we have learned since pharmacology year 1. And it goes through like all of their little like the 30th, 50th, by 30, sell at 50, like, and like MRSA coverage and everything. So that's just for your extra knowledge. But if I put it in red, it's probably because it was for this exam. Okay. So again, meningitis, give them dexamethasone. Early administration diminishes bad stuff. Bacterial. Start with empiric coverage of vancomycin and a 3rd generation cephalosporin like ceftriaxone or cefotaxime. Viral, we're going to think herpes, so acyclovir. If resistant, go to foscarnet. If we have CMV, it's going to be ganciclovir and foscarnet. And then toxoplasmosis is going to be pyrimethamine and sulfatazidine. And we're going to add that leucovorin to reduce that hematological toxicity. Fungal, we're going to AMP B. It's super bad. So make sure that you adequately hydrate and give sodium supplementation before and after to reduce toxicity. That is all of that lecture basically on one slide. And that's how I studied for farm. And I've got like every farm lecture for like heme, MSK, and like cardio, everything for the entire year. They may be out of order, but like in my drive, so you guys can have it. Okay, quiz time. You're welcome. So I did not put this in my drive yet so that you wouldn't have the answers. I mean, whoops. Okay, so we're going to exit out of this. No. Oh, there we are. In show. Okay, so let me go over to this one. Okay, so this is going over meningitis and infections plus a little extra knowledge from last week. Okay, so this is how questions are going to be asked, except they'll be in question form, not like a little chart. You've got elevated opening pressure. Cell count is going to be like 5,000. Let's say. Cell differential, we've got neutrophils, got elevated protein, low glucose, and our gram stain looks like this. What is the treatment? Okay, so I've got a vote for Vink and third generation cephalosporin. So let's think about this. Good job. So we've got big cell count, we got neutrophils, low glucose, automatically thinking we've got a bacterial infection. Then we're going to see pink dipococci. So pink are going to be gram negative. And we have dipococci, so they're going to be, we're going to start thinking Neisseria. Okay, continued. So you brought your roommate in question that presented in question 1, and I included a little picture. Here's your roommate's legs. Here's a picture. Are you yourself going to go home with any medications? Yes, rifampin. Good job. It's probably not going to be on your test, but definitely know that. Okay, question 2. We have normal opening pressure, no cell count, no cell differential. We've got elevated protein, normal glucose. Oh, yeah. And by the way, the patient has diarrhea, trouble breathing. They got tingly legs, but their arms feel okay. What do they have? Is it meningitis or is it not? They have no they have no cell count. So this is where it gets tricky. So their cell count isn't normal, and their cell differential, there's no neutrophils, there's no lymphocytes, there's no cells at all, but we just have an elevated protein. So it's not viral because our cell differential would have said lymphocytes. But why do they have these weird symptoms? They don't have neck stiffness. They might have a fever. I don't know it. I didn't give the vitals. But they have diarrhea. They can't breathe. That's not normal with meningitis and encephalitis. Their legs are tingly. That's kind of weird. But their arms are okay. So what would give me diarrhea and something that makes my legs tingly that starts going up, ascending? maybe I should have told you that they ate a casserole that had some raw chicken in it. You would start thinking about Campylobacter. What does Campylobacter jejuni give us? Yeah, Guillain-Barré. That's what this is. And then the treatment is going to be supportive care, IVIG, and plasma exchange, no steroids. So I kind of tricked you up. That's what the extra info was from last week. So their LP looks normal except for the elevated protein. So tricky. Okay, next question. Okay. Opening pressure is going to be normal. Cell count is 50. So the way I think about cell count, like I don't remember the numbers. I just know, okay, 50 looks like a smaller number. And I know that like 1,000 is a big number. So if it's a really big number, if it's like 10 after the first number, then that's going to be small. So 50. If it's got 3 zeros, that's going to be real big. So that's just how I remember it. And then don't care about the numbers. Cell differential. Whoops, didn't look. Protein, it's elevated. Glucose is normal. Oh, green stain. I forgot to do one. Look at me, forgetting to do all this sorts of stuff. Symptoms and signs. They're talking about UFOs. They're screaming and they're chewing a blanket. What common organism would this be? First off, do we have meningitis or encephalitis? Yes, we have encephalitis because they're doing some weird neuro stuff. They're not acting normal. They got some personality change. So what organism do we usually think about when we have encephalitis? And they've got like, yeah, Kluver-Bucy syndrome from HSV. So we've got HSV, we're treating it with acyclovir. So here's Gary-Busey to remember Kluver-Bucy syndrome. So see, he's got that oral thing. He looks crazy. He says inappropriate things. There he is. Question 4. We've got an elevated opening pressure. We got a big number, cell count. I didn't look at the cell differential. Protein is elevated, glucose is low, and here's our gram stain. And I put it bigger because I thought you might not be able to see the tiny little image. What is our treatment? Gram-positive Ron. Yeah, ampicillin. Good job. Question 5. H category is infant. And basically forgot to look at everything else. What is the gram stain going to tell us? And how are we going to treat them? Good job. So gram-positive, cocci and chains, group B strep, penicillin G or ampicillin. And so here's our picture of our gram-positive, purple positive, whoops, in chains, cocci and chains. And then here is how how it is transmitted from the vagina up through the cervix, up here we are in the uterus, and here it is around baby. And traveling through, getting into that amniotic fluid. Question 6. Opening pressure is elevated. We've got 2 zeros for our cell count, so medium. We've got lymphocytes. We've got elevated protein. Glucose is low, and there's nothing on the gram stain. What type of meningitis is this? Bacterial, viral, or fungal? Fungal. Good. Easy. Opening pressure is elevated. Our cell count has 1 zero. Cell differential lymphocytes, elevated protein, normal glucose, and nothing on the gram stain. What is our most common organism or virus? Viral. And which virus group? Okay, HSV is common in the US. How about anywhere? And HSV is the most common organism. Mumps is the most common organism worldwide in other countries. So enterovirus, so all of our or enterovirus, all of our viruses that are transmitted like by mosquitoes are going to be our most common. It's like 85%. Our most common cause of encephalitis is in the US is HIV. And the most common worldwide in third world countries is going to be mumps. But our most common meningitis, I know I didn't give you I didn't say that it was meningitis, but our most common meningitis is going to be enterovirus. So I don't know. I just saw it on one of the slides and thought it could be important. So threw that in there. Okay, I think this is our last one. We've got a case study example. So we've got a 48-year-old female that has neck stiffness and a headache, has vomited twice. On physical exam, you flex their neck and their knees bend. So it's not going to tell you a positive exam. You have to know what exam it is. They are alert and oriented times 3. They have no psychomotor symptoms. What is your next step? Blood cultures and a CT. Do we do a CT or do we skip to LP? Okay. So we want to make sure that we can do a LP, but they're alert and oriented. They're not saying anything crazy. Their history doesn't tell you that they've had a stroke. They didn't have a seizure today. You look, you don't see any papilledema. They have no motor deficits. Do we need to do a CT? Or can we skip to the LP? Just skip to the LP. Good. So make sure you absolutely know between, do I do a CT or do I skip to the LP? So I didn't include everything, and some of these questions sometimes I feel like are vague on test. So I just put they're alert and oriented and no psychomotor symptoms. If you just see that, or if it just says no papilledema, and you just assume everything else is negative. So just jump to the LP. Okay, what do we do after that? We got the blood cultures, we got an LP. Now what? And this is where third and fourth year becomes a little bit complicated occasionally and beyond, because sometimes they'll just turn to you and say, well, you're the doctor. What are we going to do? You got to know. What are we going to order? What are we going to do? Yeah, we're going to treat them. We think, okay, they got meningitis. We got cultures. We got the LP. Let's give them some antibiotics and steroids. So dexamethasone vanc plus our third generation cephalosporin, which we're going to go with ceftriaxone or cefotoxamine. But here's some more third generations. Okay. So same question. The CSF comes back. What do you think it looks like? Strep pneumo pops. Okay. Let's say we don't have a culture back yet. Our gram stain is going to be positive. Okay. What else? What do we have? It could be lancet shape. What does do we have high glucose? Do we have low glucose? What's our protein look like? What does our cell differential look like? Good. Human cells, high protein, low glucose, high opening pressure. Good. There we are. Okay. So our CSF comes back. You said, okay, you told us our gram stain in most common organism. Do we change our treatment? Or do we keep the treatment? You said it was strep pneumo. We had gram-positive diplococci. Do we change treatment? We said vanc and third generation cephalosporin plus dexamethasone. Nope. Treatment remains. Okay. Whoops. I forgot. Oh, well, if we saw this picture below instead, do we change our treatment? And the answer would be yes, we add ampicillin to cover listeria. But okay, so that's the end of that one. So I'll go back to the other PowerPoint. And finish up this one. Okay, so metabolic and toxic diseases of the CNS. So we've acquired toxic and genetic. And I'm pretty sure you can figure out which one's which. Okay, thiamine deficiency, vitamin B1, it's absorbed in the jejunum, so I would know where it's absorbed. Deficiencies could produce wet or dry beriberi, and then could produce Wernicke or Korsakoff syndrome as well. So when we think about Wernicke-Korsakoff syndrome, we usually think about alcoholics, but also think about things like that maybe could affect the jejunum as well. And when you get to GI, we'll learn more about things that can affect the jejunum. But it acts in carbohydrate metabolism. So people who can't metabolize maybe carbs as well might be deficient in B1. So dry beriberi is going to involve peripheral system. Wet beriberi involves the cardiovascular system, and then Wernicke-Korsakoff, which you've learned about before, affects the CNS. So dry beriberi. It's going to be impairment of sensory motor and reflex functions. There's going to be axonal degeneration. So think about peripheral neuropathy with dry beriberi. Okay. Wernicke encephalopathy. encephalopathy is going to be that triad of confusion, ataxia, and neurodeficits. So I think of CAN, confusion, ataxia, and neuro, ophthalmoplasgia. So when we look at an autopsy, we may see punctate hemorrhages in the third and fourth ventricles around the aqueduct or in the aqueduct. Korsakoff is going to be a consequence of Wernicke. So we had Wernicke, so we got that CAN plus memory impairment and confabulation. So if you forgot what that big word meant, they're basically lying and making up things. So if it's not treated, it can get worse. With the deficiency of thiamine, we have decreased generation of ADP and NADPH, and accumulation of alpha keto acids and lactic acids. So in the ER, because of this decrease, you always give glucose, but you're going to always give thiamine first. So they may be severe, they may not be, a lot of times like alcoholics, they'll be like, well, actually a patient told me this, I have to drink alcohol in order to eat any meal. But every time I go to eat a meal, I just decide not to eat and I drink alcohol instead. So he didn't eat for 3 weeks. So they may have severe glucose, low glucose, but don't just give them glucose, make sure you give them thiamine. So their TCA cycle works. Vitamin B12 causes neurological dysfunctions as well as megaloblastic anemia. So pernicious anemia is a special type caused by autoimmune gastritis with that failure of the intrinsic factor. So if there's no intrinsic factor, they're not able to absorb that B12. And it can cause this demyelinating disease in peripheral nerves. So a lot of patients with B12 deficiency complain of peripheral neuropathy when it gets to later stages. Remember that vitamin B12 is associated with reduced levels of SAM, but elevated levels of methylmalonic acid. So when we're looking at the difference between folate and B12, methylmalonic acid is going to be elevated in vitamin B12 deficiency. Early stages, I don't think it's important, but later stages, it affects the posterior columns and descending pyramidal tracts. Gross, the cord may look shrunken, and then histologically, there's going to be myelin breakdown and swelling within the vacuoles. And gliosis might occur as well. So here is a subacute combined degeneration, SCD, of the spinal cord. Hypoglycemia, so low glucose. The brain uses glucose as a fuel. Remember, if they're alcoholic, give them thiamine first. So low glucose can affect the hippocampus, the pyramidal neurons, and the Purkinje cells. Too high blood sugar causes a hyperosmolar state, and so it pulls water out of the cell and diuresis occurs and then leads to dehydration. And ultimately leads to hypovolemia, hypotension, and poor perfusion of the brain, eventually leads to coma and then death. Liver failure, they can see hepatic encephalopathy. So neurological symptoms include acidosis, including the hyperextension. It's like flapping of hands, like flapping like a bird, and hyperactive reflexes, and then extensor toe responses later. So usually, so if a patient has liver failure, and you're checking for hepatic encephalopathy, you'll learn, you don't, like, doctors always like want to check an ammonia level, but that's not actually the best thing to check. The best thing to check is to see if they have these neurological symptoms, or they've got like a personality change or altered mental status, or this asteritis. So our morphology is going to be a laminar necrosis and spongiform appearance of the layers of the cerebral cortex. Central pontine myelinolysis. Alcoholics are going to be prone to this with too rapid correction of hyponatremia. So, like my little saying goes, high to low, brain will blow, too much ICP. Low to high, pons will die. So pons will die is central pontine myelinolysis, and that is low sodium being corrected too quickly, low to high, pons will die. So too rapid correction of hyponatremia can lead to central pontine myelinolysis. And that can occur with, any rapid correction, but alcoholics might be one of the causes. And that can lead to like quadriplegia, pseudobulbar palsy, depressed consciousness, coma, or demyelination on autopsy. So we've looked at this picture before. The areas of demyelination are in the lighter color, and this Luxol blue stain is highlighting the myelin. And you can see decreased signal of the pons, and that's because of that pontine myelinolysis. Atrophy of the cerebellar vermis can cause truncal ataxia, and then atrophy of the Purkinjean granular cells. So you can see how it's all put together right here, but look, you can see like all of like the fronds of the cerebellum are like super far away. So that's showing the atrophy. Like here, you almost can't see it apart. And then this almost looks like coral, like a coral reef, I think. Okay, methanol toxicity. So this is when you need to turn on your listening ears. This is important. So methanol is metabolized to form formaldehyde, which is oxidized to formic acid. So if you see the term formic acid on your test, you need to be thinking methanol. Formic acid, methanol. And it can result in blindness. And you've got bilateral pulmonary necrosis. And toxicity toxicity is usually just direct consumption and toxicity of methanol itself. So if you see this picture with bilateral putamen necrosis right here, not our globus pallidus, globus pallidus, just our putamen. Think methanol, which again is formic acid. I know I'm like hitting that strong, but make sure you know that methanol is called formic acid. And this is the picture associated and where it's located in the brain. Carbon monoxide is going to be can cause bilateral necrosis of the globus pallidus. It can cause formation, or it can cause necrosis as well in the same area that methanol did, but really think globus pallidus. So here's our globus pallidus. See, here's our stamen. It's fine. Globus pallidus, not okay. It's necrosed. Okay. So here is like a review slide. Methanol, which is our formic acid, and carbon monoxide. And these are the names of the locations in the brain on the opposite side. And they would be necrosed. Okay. Lysosomal storage diseases. These diseases that we had to remember first year. They're coming back to haunt. So it's, of course, mutations in the genes that encode for lysosomal hydrolysis. Tay-Sachs disease is going to be that severe deficiency of hex A1, and you get accumulation of GM2 ganglioside. So go back and remember some of these again. So Tay-Sachs, hex A, GM2 ganglioside. It's going to accumulate in the brain, or in all organs, but especially the brain and the retina. So remember the retina, we've got that cherry red spot. And there's going to be concentric whorls on EM of laminar structures in these myelin bodies. So here's these whorls that we can see right here. And then large pale neurons. So that is that. So these whorls are going to be that ganglioside deposits in the lysosomes. XA, GM ganglioside, Tay-Sachs. And here again is that cherry red spot. Know that they can have seizures, weakness, impairment, pretty much all of these lysosome diseases, they're going to be mentally impaired. And then we've got visual impairment as well. And they die at a young age. Niemann-Pick disease, I think of it as like basically all of the same symptoms, except we have got involvement of the liver. It's autosomal recessive. It's accumulation this time. Instead of hex A with GM ganglioside, we've got accumulation of sphingomyelin due to a deficiency of sphingomyelinase. So Niemann-Pick, sphingomyelin accumulation due to deficiency of sphingomyelinase. It's got that cherry red spot as well. Very, very similar symptoms. But we have some liver disease as well. Gaucher disease. I think of paper with Gaucher disease. I think of like tissue paper. Oh, I guess we're not. I thought that was on here. It looks like tissue paper because of the gliosis. And then Gaucher cells are going to be in the Virchow-Robin spaces. I think you go over this again at another time, but so it makes me think of that. So you get accumulation of glucocerebroside in macrophages with Gaucher disease. I really don't think that they ask you like the triad of trismus, strabismus, and backwards flexion of the neck. But I think you just need to know glucocerebroside with Gaucher disease. X-linked adrenoleukodystrophy. So it's going to be long chain fatty acid inability to metabolize, and it can cause this increased inflammatory response in the brain. So I know that so it starts with an A. It's a very long word. I'm trying to remember how we were taught this. It presents in early childhood years. In our early childhood years, we learned our ABCDs. So that's how you remember that. And then it starts with an A as well. And we are in school for a very long time. So hopefully that can help you remember that one. So this is what this myelin loss here looks like. That's really prominent here in our right hemisphere. Mitochondrial diseases are going to be like our Melas, Merriff, or Lee syndrome. All of these are going to obviously involve mitochondria. And I think of these, like think of, it's our powerhouse of the cell, our mitochondria, and they're going to result in like lactic acid, myoclonic. So I think of sort of like I don't know. When I think of the mitochondria, I think of like a little cell. And I don't know. I think of like muscles and myopathies and clonus and red, the color red. And there's like ragged red fibers. I don't really think she asked about this, but anyways, I think that was more of a MFM1. So I think this is the last lecture. So drug and toxin actions in the CNS by McGroot. Important drugs to know. This MAC blood to gas partition, malignant hyperthermia treatment, which is dantrolene. And then SIADH, and then opioids. Okay. So we're just going to skip that. So inhalation anesthesia potency is going to be expressed as MAC, which is the minimum alveolar concentration to achieve anesthesia. So it's similar to the ED50 that you talked about in pharm. Blood to gas partitions affect solubility. So the higher blood to gas, it's going to be the slower the onset. So hang with me. I got my review slide at the end about this with examples. GABAergic withdrawals can be life-threatening. If I withdraw from an opiate, if I take an opiate, it can cause respiratory depression. If I withdraw from an opiate, it does not cause respiratory depression. It can't kill me. It might make me feel like I'm dying, but it can't kill me. If I withdraw from a GABAergic, so alcohol or a benzo, it can be life-threatening because it can cause status epilepticus. You can have a seizure and not stop. Okay, so alcohol withdrawal. If my last drink has been between, and I drink every day, let's say, if my last drink was between 6 and 12 hours, they can start the shaky nervousness. So I had a patient last year who said he drank 30 beers a day and he decided to quit cold turkey yesterday. I was talking to him in the ER and I noticed that his hands were shaky. So I ran back to the IM doctor and said, hey, like this guy is super shaky. I think we need to start him on something. So hallucinations come next, then absent seizures, and then or delirium tremens, agitation, confusion, hyperthermia, hypertension, sweating, death. So preventing ethanol withdrawal, remember we give thiamine. And then to prevent ETOH withdrawal in liver disease, we're going to go to our other than liver drugs. So oxazepam, temazepam, and lorazepam. So, and here they are, OTLs, oxazepam, temazepam, lorazepam. So flumazenil is going to be our benzodiazepine receptor agonist, the antagonist, The problem with it is that there's going to be a withdrawal and it's got a short half-life. So if we give flumazenil to somebody in benzodiazepine withdrawal, think about it. If a patient has been taking benzos every single day, multiple times a day, and I give them something to reverse it, they're going to go into withdrawal. Why do I not want them to go into withdrawal? Because they may seize and die. So I don't want to give them that. Let's say a 2-year-old gets into their grandparents' medicine cabinet and takes a bunch of Valium. I could give flumazenil in that case because they're not going to withdraw from it because they've never had it before. Make sense? Okay. So thiamine again, anyone with risk, really alcoholism, like starvation and bariatric surgery, we need to give this because we want to prevent against beriberi, Wernicke, Korsakoff. And we want to be able to metabolize our glucose. Okay, so malignant hyperthermia, know that it is a mutation in the ryanodine receptors. And a major cause can be succinylcholine or inhalation anesthetics. So a lot of times in surgery, like you on your surgery shelf of third year that you take your COMAT, it's got some anesthesia questions on there, and the anesthesiologist or the CRNAs, the nurse anesthetist, they love to ask, what is if a patient has malignant hyperthermia, or they'll like describe it without like tachypnea, rigidity. The first place they get rigidity is their masseter, rhabdo, hyperthermia, all of this. They'll say what anesthetic most likely causes it, and it's inhalation anesthetics or succinylcholine. And the second question they always ask is, what do we give? And it's dantrolene. That reverses it. And then what do you do about the surgery? You stop. It doesn't matter where you are. You make sure they don't bleed out, and then you close them up, and you'll come back and finish the surgery later. You make sure they're stable, of course. Okay, so malignant hyperthermia, ryanodine receptor, major cause succinylcholine or inhalation, and then treatment dantrolene. Okay, there's again. This is like a slide I would either put in a PowerPoint to review later for like boards, or I'll just print it out and like stick it in your first aid book, because these are so important to know. Serotonin syndrome. The major thing that I remember, okay, first off, they're taking a serotonin drug, like a depression med or an anxiety med, and then they have clonus, diarrhea, hyperreflexia. That's serotonin syndrome. Sympathetic drugs, they're going to have very high hypertension. So I think of like cocaine. So they're going to have hypertension and they're going to have tachycardia together, and they're going to be cold. So because it's all going to their heart, they're going to have other stuff, but think high blood pressure, high heart rate with like cocaine. Antimuscarinics, think of like tricyclic antidepressants, and think of other antimuscarinics. So they're going to have that hot as a hair, dry as a bone, mad as a hatter, like dry mouth, and all of those symptoms that goes with that toxiderm. Malignant hyperthermia, we talked about, they've got that rigidity. They've been given an anesthetic, so you'll have like a surgery history. You're going to give them dantrolene, and then they've got that hyporeflexia. So serotonin, we've got hyperreflexes, and with malignant hyperthermia, we have hyporeflexes. And then this one I think is hard because malignant hyperthermia and neuroleptic malignant syndrome have similar names, but neuroleptic malignant syndrome, they're going to be on psych drugs. And I don't mean depression or anxiety. I mean like big psych drugs. And they're like MAO inhibitors. And they're going to have pallor, stupor, mutism, lead pipe rigidity. So they're going to have that rigidity like malignant hyperthermia, but it usually says lead pipe, and slow reflexes, as well as being warm. But that history is going to say that they're on some big side drugs. Okay. Serotonin syndrome, or like, I didn't say that, D2 antagonist. So it's going to be like things that you would treat like schizophrenia with, or bipolar, but mostly schizophrenia. Like haloperidol. Okay, serotonin syndrome, here's that. Here is the anticholinergic, hot as a hair, blind as a bat, dry as a bone, red as a beet, mad as a hatter, full as a fly. And here is my review slide. So the thing, besides the toxidromes and withdraw, I guess I didn't like mention this part. Imipenem and Celastin have a high risk of seizure as well, and have that withdraw or effect. And then, so those are things that may cause seizure, as well as withdrawal from benzos. And then inhalation anesthesia. If it has a low MAC, it is very potent. If it has a low blood to gas, it has fast onset. Low oil to water, it's slower diffusion. So low MAC, very potent. Low blood to gas, fast onset. And then, so I would know this. I would know about malignant hyperthermia, and I would know about like GABA withdrawal seizures. So that is it. If you have any questions or anything, let me know. It's been great tutoring you guys. I think this is my last session.